Legal standards and practice guidelines for the determination of brain death vary from state to state in the U.S. and between different countries in the world. Each physician should be aware of the legal standards and practice guidelines in his country. In the U.S., there are some differences between states, and state laws should be reviewed. Consult Chapter 5 of the accompanying text for further information. Here we demonstrate a brain death examination and apnea test. But before the test, we must determine that the patient is meeting certain prerequisites. 1. Is the patient normothermic at 32 degrees centigrade? This is the core temperature taken from a sensor in the patient's bladder catheter. 2. Does the patient have a normal arterial PCO2 level? We should consider that many patients are hyperventilated for the purpose of reducing increased intracranial pressure, resulting in low arterial PCO2 levels. 3. Have any sedative or neuromuscular blocking drugs been recently administered or excluded? And 4. Is the patient hemodynamically stable with a normal blood pressure? If drugs are not a factor and the other indicators are normal, then we can proceed to examine to see if the patient is brain dead. The first thing we do in a series of tests for brain death is assess lack of motor response to pain. The following pain stimuli are usually reliable for testing purposes. With our thumb, we press hard on the supraorbital nerve and look for a response. Alternatively, we could also press on the temporomandibular joints and look for a response, such as movements in the patient's extremities. These responses should be absent. Then, with a pen or similar small blunt object, we press on a fingernail bed to see if there is any movement in the extremities. We press on nail beds on each side of the patient's body. Movement in the upper limbs should be absent. Then we apply pain on nail beds at both feet, looking for a motor response in the legs. These responses should be absent as well. In some cases with this stimulus, we will see a triple response. But within this context, this is interpreted as a spinal reflex. Other spontaneous movements such as finger flexion or slow arm rising can be seen. The next thing we examine is a series of cranial nerve reflexes. First, we assess the size of the pupils, whether they are narrow, wide, or neither wide nor narrow. Typically, in patients who are brain dead, the pupil is in the mid position, and neither narrow nor wide, because both the sympathetic system and the parasympathetic system inputs to the eyes have been disrupted. Then we examine the pupil response to light on both sides. Response should be absent. Next, we open each of the eyes in turn and touch the corneas with a wisp of cotton to look for a cornea reflex. The cornea reflex, a notable blink of the eye, should be absent. Then we further confirm the lack of a reflex by dripping a few drops of saline solution on the cornea. Then we press hard with our fingers at the temporomandibular joints to see if there is any face grimace, clenching teeth response, or any other movements in the body. Both should be absent. The next test in the sequence is to do oculovestibular or caloric testing. We place the head in a 30-degree position. This changes the horizontal position of the ear canal to a vertical position. We mark on the outside of the eyelids the location of the pupils for a baseline reference. Then we insert 50 cc's of cold water into the ear canal. The eye should not move toward the cold stimulus. After a 1-minute wait, we repeat the procedure on the second ear, then inserting 50 cc's of cold water into the second canal, looking for the lack of an eye response. It is important to note that a patient with an intact oculovestibular circuit, whose ear is injected with cold water, should normally respond by slowly moving his or her eyes toward the stimulus. Next, we look for the lack of a gag response by putting a tongue depressor in the patient's throat. Then we disconnect the ventilator. And, inserting a suction tube, we look for a cough response after suctioning the trachea. An absent cough response should be documented. Several repeated attempts should be made to be completely certain that no cough response is present. With all these tests completed, we go to the apnea test. But before we do the apnea test, we must pre-oxygenate the patient by switching the ventilator on maximal oxygen administration at 100% FiO2 for 10 minutes. Simultaneously, we reduce the ventilator frequency to 10 breaths per minute, which allows the arterial PCO2 to climb to a normal range. After 10 minutes of oxygenation, we draw a baseline blood gas. After oxygenation, we should have an arterial PO2 of more than 200 millimeters of mercury. The arterial PCO2 should be around 40 millimeters of mercury. Then, if the patient has a normal blood pressure of at least 90 millimeters of mercury with no negative fluid balance and is oxygenating well, we can start the apnea test. To do the apnea test, we remove the ventilator, put a catheter inside the endotracheal tube of the patient at the carina, providing 6 liters per minute of oxygen. While the patient is apneic and receiving oxygen, we will be looking for spontaneous breathing at the abdomen and chest. We recommend intermittently placing your hands on the chest and abdomen to feel for potential subtle breathing excursions. You continue to closely observe in this way for 8 minutes. At the same time, we watch the monitor and look for changes in heart rhythm, changes in blood pressure, and, most importantly, changes in oxygenation. The apnea test should be aborted when there is a definite decrease in blood pressure and oxygenation, or when sudden cardiac arrhythmia occurs. If during this time there has been no breathing, you draw another specimen for a blood gas test. We continue to observe the patient until the blood gas becomes available. Using a bedside device, a PCO2 measurement takes approximately 2 minutes to do. If the blood gas test returns with a PCO2 of 60 millimeters of mercury, or an increase of 20 millimeters of mercury above a normal value, then the apnea test is considered positive. The patient is considered apneic, and we can declare the patient brain dead. This is the official time of death. The ventilator is again reconnected. When trying to demonstrate brain death, there are 3 common situations that can interfere with a clinical examination: ventilator autocycling, pulmonary edema and poor oxygenation, and cardiac arrhythmias. Be sure to see if there is evidence of ventilator autocycling. This is a commonly observed phenomenon when the ventilator simulates spontaneous respiration, even when no spontaneous respiration is present. If not recognized, this phenomenon erroneously suggests that the patient is still triggering the ventilator. This occurs when the pressure in the tubes changes, resulting from, for example, secretions or water in the tube, or if a chest tube is present in a patient with traumatic lung injury. We see it demonstrated in this video. We see the display panel of a ventilator connected to a test lung, set at assist control. This setting is indicated by the C in the upper left-hand corner of the display. We see it indicates several ventilator breaths. After resetting, now no breaths are produced and a straight line is seen. Then we see a finger touching the screen and reducing the V trigger level. Increasing the sensitivity produces a false rhythmic breathing pattern due to ventilator self-cycling. As indicated by the S in the upper left corner of the monitor, the ventilator is falsely reading this as spontaneous breathing. Pulmonary edema may make oxygenation very difficult. Many patients need PEEP ventilation. Discontinuation of the patient on high PEEP, more than 10 centimeters of water, could cause sudden deoxygenation and cardiac arrhythmia, including cardiac arrest. Reduce PEEP to 5 centimeters of water and see if this does not lead to oxygen desaturation. If oxygen desaturation occurs, the chance of an apnea test with hypotension or even cardiac arrhythmias, including cardiac arrest, is high, and the apnea test should not be performed. A confirmatory laboratory test is indicated to complete the evaluation. Cardiac arrhythmias or hypotension may occur during the apnea test. Usually, they are a sign of severe acidosis and are usually observed at the end of the test. If cardiac arrhythmia or hypotension occurs, then the apnea test should be aborted. When these complications occur, if possible, a new blood gas should be immediately drawn before reconnecting to the ventilator. It is possible that the PCO2 level already has reached its desired level. If the PCO2 level is more than 60 millimeters of mercury, or 20 millimeters of mercury above a normal baseline PCO2, then brain death can still be declared. This is how we examine patients to determine brain death. Please refer to Chapter 5 of the accompanying text for further study.